Hi, Linda.
Hi, Henry.
Hi, how are you?
Good.
Thanks for presenting. So we'll give everyone till like 1:05 and then
Okay, sounds
you
good.
can get going. Um, Thanks for replying with the needs assessment so quickly. That was
Oh,
helpful.
no problem.
It's up to you. I mean, they don't have to come over every week.
There are a whole bunch of
Hold on
people
a second.
in her department that are.
Hold on.
All right, Linda. So it's 1:05, so I think we can get started. So this week, Linda's joined us from Cohen's Children's Medical Center in Long Island. So thank you again, Linda, for presenting, and you can take it away.
All right, thank you, Henry. Let me see if I can share this. Okay, can you see the screen okay?
Yep.
Okay, so hi everyone, I'm Linda. I'm the ultrasound fellow here at Cohen Children's Medical Center in Queens, Long Island, New York. I'm going to be presenting some cool cases we've seen over the past few months. All right, so the first case, so this is a 5-month-old female presenting with 6 days of fever. She was actually seen in our emergency room about 3 days ago, and 3 days prior to this presentation, where she just had a fever, no other real symptoms, no cough, congestion, otherwise feeding okay that day. And at that time, a urine and RVP, respiratory viral panel, were done, and they were both negative. So she was sent home, likely viral illness. So 3 days later, at the 6-day mark, she went to her pediatrician. The pediatrician noticed she was dehydrated and wasn't drinking as well. And with the 6 days of fever, she was sent back to our emergency room. So in the ED, this is actually a patient that was signed out to me, but she initially, when she presented, she seemed to be moderately dehydrated, but otherwise well appearing in terms of her activity levels seemed to be okay. She was responsive. And in further history taking from the parents, they started saying, and they were telling the residents that the patient, even though she's 5 months, she was starting to sit up on her own about a week ago. And then this week, with the onset of the fever, she stopped sitting up and wasn't really moving her head as much. So with that history and then the physical exam on initial like I was saying, she looked well appearing, but she had some secretions pooling at the mouth, even though she was smiling. She did have some stridor. It was difficult to see the back of her oropharynx, the posterior oropharynx, because she was like a chubby little 5-month-old. But no obvious erythema or swelling that was noted in the posterior oropharynx, and her TMs were normal. The rest of her exam was pretty much normal, but there was a questionable decreased tone in that when you examined her, she's laying in the bed, but she's not really moving that much. But she's like looking at you, she's tracking you, she's smiling, but she's making a point not to move as much. So that being said, because of the stridor, on initial workup, they had put in an IV, they got some lab work, and they did a lateral neck X-ray. And based on the lateral neck X-ray, over here, even though initially a deep neck infection wasn't what they were thinking, this was what was noted. So an increased area in the prevertebral space. So based on this, me and the fellow on Sinai, when we went to go see the patient, first we did we kind of like pulled down the chubbiness or the fat of her neck, and we saw that there was actually a significant swelling on the left side of her neck. So we put a probe on it, and this is what we saw. So just to orient, so this is the swelling was on the left side of her neck that we saw on physical exam. I think our probe marker might have been actually on the rookie mistake on the other side. So this is actually the right side that we're seeing first here, and then we're moving towards the trachea, and then this is what we're seeing on the left side. So this is more of the left side. Any comments on this, or what do you guys think we're seeing here? I have some more images as well.
So Linda, this is midline, like trachea. I just missed it. Or
yes. Oh, so the way I was scanning, this was midline trachea. So I started off on the right side here, midline trachea. That's right here, and then I just scanned again towards the left side. And then same thing right here. So now this is also now this is going from the midline trachea to the left side, a transverse view of the neck, anterior neck. Any thoughts? I'm going to go on to another image as well. We put some color on it. Although she was moving a lot at this point, just trying to move her neck. And then this is just this other one. So any thoughts on what we might be seeing?
No, it looks like an RPA, but it's huge, massive RPA.
Right, exactly. So when I was initially looking at it, I hadn't actually scanned that many RPAs prior to this. Actually, this is my first one that I've scanned on my own. I didn't really know exactly what I was looking at. And I'm going to reference a paper, shout out to Henry, Adam, and Laurie, that they looked at a view of how to scan RPAs. But it did look like an abscess to me, given that there was some posterior enhancement behind it. And then going through the paper that was put out by you guys, so visualizing the vessels and then possibly the vertebral bodies behind it. That's actually the CT I'm going to show you guys. This is the vertebral body. I believe that we're seeing actually over on this side, and then the vessels on this side, and in between this space right here is if there was an abscess, that's where you would look. So given the posterior enhancement and this abscess looking structure that I was seeing, we thought it probably was a retropharyngeal abscess. So we had a CT done of her neck, and this was the view. It was a massive retropharyngeal abscess in a 5-month-old. Given that retropharyngeal abscesses usually, this is just another cut of the CT, don't occur, I mean, not usually, they don't usually occur at this age. It's in a 5-month-old, this wasn't the first thing on our differential. But this was pretty impressive. And it was also impressive to me how well appearing she looked. I mean, she just wasn't swallowing, and so all her secretions were just staying in her mouth. But then once you suction her, she's smiling at you. She's like interactive. So they went in and they, I'll give you guys a little follow-up. They went in, they operated, they took out they took out the abscess, they put on antibiotics. She was admitted for about 7 days afterwards on IV antibiotics. Afterwards, she did really well and she went home on oral antibiotics for 3 weeks. So just a shout out on this paper. So I actually read this paper after I did this scan because I was looking at how people usually scan retropharyngeal abscesses. So this isn't the way I did it. I went right on top of the trachea, but especially I guess if it's not so whoppingly big, they would. Oh, how much did they drain? Actually, I don't know. I didn't see. I think they said 5 ml actually, if I remember right, which doesn't sound like that much, but her neck was so little, so maybe that's why it looked like so much. So this is the view I guess we normally would look for our RPA, where we visualize the vessels, the carotid and the carotid artery and the jugular vein, and then the vertebral artery, and the space in between that is where an RPA would be if present. And this is using a linear probe going in this direction, I guess more transverse, where the indicator is pointing to the ipsilateral ear of the abscess. Did I say all that right, Henry? If you could correct me if I'm saying anything wrong.
That's perfect. Yeah.
Yeah. So this is probably the biggest retropharyngeal abscess I've ever seen, and especially in a 5-month-old.
Yeah. Did you scan the other side by any chance?
Yeah. So when I just have one clip of the other side, but my first one right here, this is actually starting on the right side and then going towards the trachea right here and then going over to the left side. So this right here is the right side.
Yeah, it's a massive RPA. Oh yeah, that's the biggest one I've seen.
Yeah. Any comments or anything on that case? Cool. I'm gonna move on to the next one. All right, so this one was a 3-year-old male who was presenting with 5 days of painless right testicular swelling. He was actually being followed by his pediatrician, who sent him for a ultrasound of his testicles outpatient, where on that ultrasound, they showed a questionable pulsatile vascular structure in the scrotum. So he was referred to the emergency department. So one of our other fellows, Tasso, did this scan. Well, I'm going to show you the scan. So on exam, he did have a pretty significantly swollen right scrotum, but it was not tender to palpation. He was pretty well appearing. There was a cremasteric reflex bilaterally, and the left scrotum was within normal limits. So this is what we're seeing here. I'll go through a few more. Any thoughts so far? I'll do a few more. This is, okay. I'll go back to the other ones really quick. So here, I mean, it looks like fluidic and anechoic fluid are what seems like what we usually will see in a hydrocele. But then we're seeing some structures that, I don't know, I haven't really seen before. So, and this is probably what they were questioning on the outpatient ultrasound. Any thoughts on what this could be or what it is?
I mean, it looks like an abscess. It's an anechoic structure. I'm not seeing any swirled, but
yeah, these are just some stills of it as well.
This looks like small bowel.
That was the question. Yeah, Matt's here. He's saying possibly small bowel.
That's during night appearance.
Yeah. So this is I'm gonna go over what they saw as well. So this is just we put some color on it to see if we could see this vascular structure that they were talking about, but we're thinking this is likely what they were seeing. Any thoughts on this?
It almost has the echogenicity of like sort of like rouleau formation when you've like tourniqueted somebody for a while. It
Mhm.
could be some weird like varicocele that's just like kind of hanging out down there.
Yeah. Yeah, I think all these because when I was looking at these scans too, I had a couple of different differentials, and really, when there's fluid in the scrotum, I guess it could be any of these, right? Going forward, so this is just a few more. So now we're Tesla scanning up, following the cord. And any thoughts on this, or does this change your differential in any way? It just looks weird, right? It looks so funky. Let me see if I have some more. Nope.
Did you feel any mass like in the inguinal region, or was it just in the testicular region?
Yeah, it was just no mass is felt. It just felt, yeah, swollen in the testicular region.
But nothing connecting to the inguinal, because it almost
No.
connecting to.
Nope. So I'll go over what radiology read it as, and then we can come back to these images and try to discuss it. So just a quick overview. So hydrocele in general, so there's communicating hydrocele and non-communicating hydrocele. I haven't actually gone over this in a while, so it was good to go over. The non-communicating ones are within, are captured within the tunica vaginalis. So it doesn't connect up to the past the spermatocord into the peritoneum. Communicating hydroceles are because of a patent processus vaginalis. So that fluid, you'll see it in the scrotum as well as tracking up by the spermatocord into the peritoneum. And then in terms of other things that other hydroceles, so there's a non-communicating, communicating, and there could be a spermatocord hydrocele, so a hydrocele of the actual cord, which is actually what we were seeing here. So this, so on the radiology ultrasound that was done in the emergency room, the radiologist read this as a large right hydrocele with a spermatocord hydrocele, both with debris. So after seeing that read, I went back to the images. So I guess in these stills, what you're seeing here could be the spermatocord. And correct me if you guys think that it might be something different, but could be the spermatocord. And then coming off of the spermatocord here is another, it's like a cyst-looking trapeze structure. So a spermatocord hydrocele within the communicating hydrocele that's in the scrotum. And then this right here is the testicle. So let me just play that clip again. So this right here, this structure is a spermatocord hydrocele is what it was read as. And radiology got pretty much the same images as this.
Interesting.
Let me just see. Any thoughts or comments on this? Have you guys ever seen anything like this before? And the vascularity, I'm guessing it was just because of movement of the fluid that was inside both of these that was showing this possible pulsatile vascular structure on the outpatient ultrasound. Oh, it looks like, yeah, so Nino saying that it looks like it does. Yeah, I agree. It does look like it communicates because it on these structures it does look like it's tracking up past the spermatocord as well. So yes, they were reading it as both that like a communicating hydrocele as well as a spermatocord hydrocele. And he's scheduled for a urology follow-up soon. Cool. Any questions or comments on that case? All right, I'm going to move on to the next one. Okay, so this one, so it was a 17-year-old male with a history of osteochondroma to the left iliac crest. He was status post resection of that 2 years ago, and now he's presenting with right-sided lower leg pain times 2 days. In the ED, his vitals are all normal. He's pretty well-appearing kid. fit. He did have, so in terms of his MSK exam, he did have range of motion that was limited at the right ankle. He had denied any trauma to that area, but there was swelling and erythema to the medial malleolus. Just on the rest of the physical exam, though, as the team was examining him, they did notice some tenderness or palpation in the right lower quadrant. And so based on that, so while they were waiting for x-rays of the ankle to be done, they decided to scan his belly, looking possibly for an appendicitis or just looking for an appy. And then this is what they saw. So this is the right lower quadrant of the abdomen. Also looks kind of funky, but any thoughts on what we're seeing here or what we're not seeing? On physical exam as well, as I was reading through the notes, it seems like he was tender to palpation in that right lower quadrant, but they may have also felt a possible mass or some sort of hardness in that area, if that helps with the scan at all.
Yeah, Linda, I'm looking for the psoas and the iliac subunit right lower quadrant, but I can't see
Can't
any of that in there. 'Cause
Yeah.
there seems to be like a something anechoic, right, where I expect it to be, but yeah, I can. That's what I would be looking for. So I no idea what I'm looking
Yeah,
at.
agreed. Okay. And I think that's it. So Tasso did this scan as well, and I think that's exactly what he was thinking as well. He but there is that an anechoic space right here. Once we know the rest of the story, we'll see why. But it seems to be something here causing this anechoic or the shadowing behind it. So I guess just in terms of ultrasound, what usually does that is some sort of bone. So that being said, world's biggest appendicular. Okay, yep, there's shadowing. Perfect. So let me just see if this is the same one. Yep. And then in terms of, he put some color on it. There was not really any color going through that anechoic area. There's shadowing behind it. There seems to be something there that's causing some shadowing behind it. And then they did an abdominal x-ray, and this is what they see. So basically, this is a bony outgrowth. So this kid had an osteochondroma of the left iliac crest that was resected 2 years ago. And so now he has one of the right iliac crest. And this bony structure is a lot of poop. This is what we're seeing on the ultrasound, this bony structure. So also known as exostosis. But just in terms of his radiology of his ankle, also seeing some bony growths at the ankle and also at the proximal fibula / tibia. So what this kid had is something I actually haven't heard of much in the past, but he has a syndrome called hereditary multiple osteochondromas or hereditary multiple exostoses. I don't even know if I'm saying that right, but it's characterized by 2 or more osteochondromas in the appendicular or axial skeleton. It's autosomal dominant and pretty rare. Initially, it starts off as usually painless masses and then becomes painful or can cause a deformity. So when does it need intervention or excision? Is usually when it's usually not necessary, but if it's causing local irritation, deformity, or concern for malignant transformation, which is the concern with these bony overgrowths. So going back now to the scan, just to look at it one more time. Knowing that history and then seeing that x-ray now kind of makes sense that this kind of does look like bone in the abdomen. Any comments on this? Pretty interesting. Cool. All right, I'm gonna move on to the next one. Okay, all right. Okay, so case 4. So this was a 13-year-old female who had a history of constipation in the past and presenting now with abdominal distension, pain, and urinary retention times 1.5 days. So she was saying that it was just hard for her to urinate, and even if she felt the need to urinate, she couldn't urinate. She was actually seen at an outside hospital initially, and she was treated with an enema with no improvement. She did have a small bowel movement, but she didn't have any improvement in her abdominal pain or her urinary symptoms. She still felt the need to pee, but she couldn't. They placed a Foley catheter in the outside hospital, and they took out, I think, about 50 cc's of urine, but still the abdominal pain persisted, so she was transferred over to Cohen's. there's quite, when I was reading the note, it was questionable. I couldn't figure out when they did a CT scan. At some point, a CT scan was done, but just on physical exam in Cohen's emergency room. So she was uncomfortable, but she looked well hydrated. The rest of her physical exam was pretty much normal, except that she did have a slightly distended abdomen, and she was tender to palpation in all lower quadrants. She did seem uncomfortable though because of the pain, even when you weren't palpating her. So the PEM fellow that was on the shift decided to place a probe on the belly in the pelvic area, and then this is what he scanned. Of note, she still had the Foley catheter in place. Any ideas? Not the bladder. Agreed.
Did you say she had her period yet?
She is premenstrual.
And she's 13?
Yep. Hematocopus, I see it in the chat. Yes, so that is what we're seeing here. So in the initial images here, we're seeing the bladder with the Foley in it, and then behind the bladder, this large collection of something. So going forward to some more scans of it. This actually, so this is just a trans view of it. It was hematocopus, so a large amount of blood in the vaginal, in the vagina. I'm going to show you some more clips. And then this was her CT scan. So on the CT, you're seeing this is the bladder right here with Foley, with the Foley in place, and then this is her large hematocopus. And then this, I just put the picture of her uterus as well, which this was the vaginal wall and this was the uterus. So pretty significantly dilated. Examination. Yep. Yeah, so that was we thought that was a great case, especially for it was the first shift PEM fellow that did it, and just to broaden the differentials and not just think that it could be still constipation, just using the ultrasound as a way to augment the physical exam, like Leigh was saying, transverse septum would miss by external. Yeah, yeah. That's a great point. Urinary retention is usually a good reason to focus because you're likely to see get some answer. Oh, so the CT. So the CT, I believe was done. I'm questioning when it was done. I believe it was done in the outside hospital prior to transfer to Cohen. So I think it was decided to transfer to Cohen's for further evaluation of her abdominal pain. But a CT was done prior to transfer. So I don't know if they had actually known the results of the CT by the time they had come to the emergency room. But then it was relayed later that that's what the CT showed. So. And then she was admitted, and I believe it was gynecology that did this, that did the surgery. Any other questions or comments on this case? It was just I just thought that was a really cool scan.
I came on to shift with one of these about someone who sort of clinically fit it about 3 weeks ago, and they were waiting for their ultrasound, and I made my fellow go scan him, and she was very classically so.
Huh.
Amusingly, mom had also had the exact same thing.
Oh,
in
interesting.
age, and like we told her what we thought it was. She's like, "Oh, really? You think it could be the same thing?" And we're like, "Hello." It was like a year post her sister's menses initiation, and it was fairly
Wow.
amusing and interesting link between parent and kid.
It is interesting. It's hereditary, or I guess it could be hereditary.
I'm not aware of it otherwise, but it was hard to argue in both mother and daughter.
All right, cool. All right, I'm going to move on to the next case. All right, so This one is an 8-year-old female with abdominal pain for 5 days. So it was severe on day 1 and 2, and then it kind of resolved on day 3. She wasn't seen anywhere during that time, and then it returned as a dull, persistent pain over the last 2 days. And then over the last 2 days, she also developed a fever, Tmax of 103, and a decrease in appetite and PO intake. So that's when she went to the pediatrician initially, and the pediatrician referred her to the emergency room because of her abdominal exam. So on physical exam here, in the emergency room, she was uncomfortable, but she was well hydrated. The rest of her physical exam was pretty much within normal limits, except for the abdomen, which was mildly distended. There was some tenderness to palpation in the right lower quadrant. She had some guarding, and she had some rebound tenderness. In the emergency room, she was febrile to about 101, and tachycardic, I believe, to about 130. And this is actually some images done by Dr. Tang. So he put a probe on the right lower quadrant, and this is what he's seeing. I'm gonna go over to the next image. Any thoughts? I'll put some more. So any ideas?
Nasty looking appendix or
Mhm.
some type of other intra-abdominal mass or abscess.
Yeah. Yeah, I agree. Let me see if I have some more images before I explain what we're seeing here. Exploded appy, ruptured appy. Yep. I'm gonna go to a few more, just because I thought these pictures are so nice. So this was actually, so it was perforated appendicitis. So here, I'm gonna go back to this image, which I thought showed it pretty nicely. So you can actually see the appendix here, somewhat intact, and then it kind of explodes here into this abscess formation over here. And the abscess we're seeing a little bit more clearly over here. So this is the end of the appendix rupturing into this abscess formation. I just thought her history was also kind of interesting because I mean, is it kind of like a ruptured TM where you have the rupture and your pain gets a little bit better, and then the abscess formation makes the pain come back? The fact that her pain had improved on day 3 and then persistently got worse over the next 2 days, though. Interesting. So here,
Did she get evaluated before, or
no. So she just had just went to the pediatrician this day. Here also you're seeing the abscess over here, and coming off the appendix over here. Yeah.
And was there any free fluid in any other areas?
No, not that. I believe when Dave had actually done a fast exam on this patient as well, and I didn't see any free fluid in that area.
Okay.
In any of the 4 areas.
that's interesting.
Yeah. So in terms of just like ultrasound points, I mean there is posterior enhancement behind this, whatever structure this could be. So likely an abscess or fluid collection over here, and then it's just cool to see the appendix coming right off of it. Cool. I might look around the liver fluid. Yep. Yeah. Cool. And this is my last case, I think. So I'll go one more case. So this was just an interesting one in terms of how it led us to do the ultrasound. So this is a 3-year-old female. She was developmentally delayed and G-tube dependent, presenting due to the reason they came to the emergency room was because she was having a nosebleed at home. But in the emergency room, she was found to be febrile, tachycardic, tachypnic, and so she met sepsis, our code sepsis criteria in the emergency room. So, and on physical exam, when you looked at her, she did look a little bit ill appearing, that she did look dehydrated, and not as active as usual as her parents. So they started a sepsis workup. They put an IV, they got some labs. Because she was had a little bit of rhinorrhea / a cough, a chest x-ray was done as well as part of the sepsis evaluation. So this is the chest x-ray that was done. But what's interesting about the chest x-ray is that, I mean, anyone see anything abnormal on the chest x-ray? Or anything that catches your eye? She's 3, yeah. Because to me, when I looked at it, I really didn't see anything abnormal. A little bit rotated. Left upper lobe aspiration, yes, yeah. Pneumomediastinum. That wasn't read as on the radiology read. They didn't read it as that. But what they did note in the radiology read was this area right here. Are you guys able to see my arrow? I hope so. This area right here, they read it as possible cholelithiasis, which was interesting. So so Dr. Mack was here that day. So he did that's what led us to do a right upper quadrant ultrasound, thinking that maybe it could be. I mean, yeah, I see what you're saying here, like there does, or maybe appeared maybe some parts of a pneumonia as well. But that wasn't read in the radiology x-ray, so they thought maybe was it something like cholecystitis that was leading to her fever and her presenting symptoms. So a right upper quadrant ultrasound was done at that point, and this is what was seen. So in terms of what we're seeing here, so it does look like stones in the west sign, yeah. That is what we're seeing here. So a good amount of stones in the gallbladder, but the gallbladder also looks pretty collapsed, and inside of it looks completely like stones. And then just going forward, just some more pictures of the WS, the west sign. And then just measuring the, we were able to find the common bile duct, and that was measured, and that was within normal limits. And the anterior wall of the gallbladder also was measured, and it was also normal as well. So it seems like it was just an incidental finding of cholelithiasis that was found on chest x-ray, which was interesting. And then we see this on the ultrasound. And then she was admitted, I didn't follow up fully on this patient, but she was admitted, received antibiotics for, I believe, 1 to 2 days, and then she was discharged home. Nothing else, no real source for the fever was identified. Cool. And that's all I got for you guys today. Any comments on any of those cases, or any other, you guys see anything similar in any of your institutions? Thank you.
No, thanks, Linda. That's the biggest RPA I've seen. So
Yeah.
I'm glad you heard. So that was good to see. And thank you again for presenting.
Yes.
Just one quick announcement before everyone starts logging off. The P2 Network is having a conference next Tuesday. It's going to be on use of POCUS and research limited areas. If you guys are interested in, it's free. I'll send in the group text, I'll send everyone the link to sign up. So another great opportunity to get more POCUS training and teaching. So a great collaboration. So, but thank you again, Linda. And I'm going to
No
send the
problem.
link right now.
Thanks for having me. Thanks, everyone.